So 20 minutes for obstructive jaundice is too short. But for undergraduate level, I will just give you a bird's eye view and certain important aspects of it, right? So this will be an interactive session, not monotonous, right? So brush up of your anatomy. Can anybody faster சொல்ல முடியுமா extrahepatic biliary apparatus? Where does it start? Yes, sir? Make it fast. Right and left hepatic duct, they join to form the common hepatic duct. It's joined by the cystic duct to form the common bile duct. What are the parts of the common bile duct? Supraduodenal, retroduodenal, infraduodenal and intraduodenal. Okay, so this is about your anatomy. Then you have the physiology. How much amount of bile is secreted per day? Yes, and 75% is from the hepatocytes and 25% from the cholangiocytes. Okay, what is the normal pressure in the CBD? It's 15 to 25, and when the pressure rises above 35 centimeters of water, secretion stops. Okay, so that is the reason beyond 40 mg the bilirubin level doesn't rise. Okay, so this is your bilirubin metabolism. Okay, I think you know this. Only I just want to highlight only a few things. So only when the secreted bile enters the GIT, it undergoes enterohepatic circulation, and your urobilinogen and stercobilinogen are formed. Otherwise, they are not formed. Okay, that is the reason you don't get a, what color stool you get in obstructive jaundice? Clay colored stool, because stercobilin is not formed, because bile is not entering the GIT. Okay, what about urobilinogen in the urine? Again, it has to come from the enterohepatic circulation, right? So you don't get urobilinogen in the urine, right? So this thing you have to keep it in your mind. And jaundice is a symptom or disease? It's a symptom. So don't say jaundice is a diagnosis. So what is this? These three things together constitutes the what jaundice it is? This is obstructive jaundice. Okay, you have yellowish discoloration of sclera, and what is the second picture? Pruritus, and the third picture is clay colored stools. Okay, so what is jaundice? It's yellowish staining of body tissues produced by an excess of circulating bilirubin, right? And it could be an obstruction in the intrahepatic or extrahepatic biliary apparatus obstruction. So where all the obstruction can? So how can you classify the obstruction? Yes, extraluminal, intramural and intraluminal. Okay, intraluminal is commonest is stones. Okay, parasites and foreign bodies can come. Intramural is your atricias, sclerosing cholangitis, benign strictures or tumors of the bile duct. And extraluminal, yes, good. Nodal disease, potapatis nodes or malignancies of the liver. Apart from this, we have few conditions like CA head of pancreas and periampullary carcinoma. Okay, and pancreatitis can also cause obstructive jaundice. And you have one classification called the Benjamin classification of obstructive jaundice. Type 1 is complete obstruction, 2 is intermittent obstruction, type 3 is chronic incomplete, and type 4 is segmental. You can go through your books. And this is about the pathophysiology of biliary obstruction. So in obstruction, the pressure may rise up to 30 centimeters of water. So what happens in the pathophysiology? When there is cholestasis, the biliary pressure rises. There will be disruption of the tight junction between the hepatocytes and the bile duct cells. That causes increased permeability across the biliary canaliculi. And there will be bile reflux into the liver sinusoids. There will be marked polymorphonuclear leukocyte infiltration into the portal triad, going in for inflammatory response, fibrogenesis and deposition of collagen fibers in the portal triad. So ultimately, what happens? If not treated, hepatic fibrosis and atrophy of the obstructed liver happens. So this is the sclera is discolored, and obstructive jaundice. What is the color typically described in the book? greenish, olive green, yellow. Okay. When do you get a lemon yellow? Lemon yellow jaundice? Hemolytic jaundice is lemon yellow. Okay. So where all you will see, where all you can find the yellowish discoloration over the frenulum of the tongue. When it is seen in the sclera, it's more than 2.5. When it is seen in the skin, it is more than 5. Right? In pediatrics, you have a scale. What is that? Yes. So when the soles are involved, how much? Yes, good. So what is this? Itching. Why itching occurs? Deposition of bile salts. Okay, and central nervous system opiate receptors are stimulated and causes itching. What is biliary colic? Yes, when the biliary extrahepatic biliary apparatus is obstructed, you get a right upper quadrant pain, or the pain may be present in the epigastrium and will be radiating to the upper back and shoulders. It will be precipitated by fatty meal. Why? Because due to gallbladder contraction, and it's a severe gripping in nature type of pain. What is this? This is Murphy's sign. What is this? This is a sign of acute cholecystitis. Patient in sitting position, fingers hooked around the right costal margin at the right lateral border of the rectus, and the patient is asked to take a deep breath. The patient will wince with pain and catch his breath. This is typical of Murphy's sign. And what is this? Good. What is that? This is called, what sign is this? Tell. Thomas sign. What is this Thomas sign? Silvery stools. When do you get this? When clay colored stools, in obstructive jaundice, when clay colored stools is mixed with melena, you get this silvery stools. And the sign is Thomas sign. Okay? And you get weight loss due to malabsorption in case of secondary to tumors, and steatorrhea due to malabsorption. Then you have deficiency of A, D, E, and K. What are they? They come under what classification? Fat soluble. Okay, because there is fat malabsorption. These fat soluble vitamins are going for deficiency, and according to the specific vitamin deficiency, you will get all these symptoms. And palpable gallbladder. If you palpate a gallbladder, what will be the typical description? From this side? I am not hearing anything from this side. How will you typically describe a palpable gallbladder? It will be a tense globular swelling projecting downwards and forwards from below the liver at the lateral border of the right rectus muscle. Will it move with the respiration? Why? Because liver moves with respiration, gallbladder is attached, so it moves with respiration, and it will be continuous with the liver dullness. And if it is a case of carcinoma gallbladder, the consistency will be hard. Otherwise, it will be a tense globular swelling. And what is this Courvoisier's law? Everybody should know. Okay, and it is not your own law; it is Courvoisier's law. So, in the words of Courvoisier, it is in the presence of jaundice. If the gallbladder is palpable, it is unlikely to be due to stones. Why? Because stone causes inflammation and fibrosis. Okay, so the gallbladder cannot distance. Whereas in case of malignancy, there is no inflammatory changes in the gallbladder, so the gallbladder will distend. Exceptions are there. What are they? Double impacted stones, large stone in the Hartmann's pouch, and empyema gallbladder. What is the empyema gallbladder? Pus in the gallbladder. Okay. And can there be hepatomegaly in obstructive jaundice? Why? It is due to hydrohepatosis. What is that? Because of the dilated biliary, intrahepatic biliary radicals are also dilated because of the stasis, and the liver will be smooth, firm, and non-tender. If it is due to metastatic deposits, it will be hard nodular liver. That is the difference. And what is this triad? Fever, jaundice, and right upper quadrant pain. And who found this out? Who is he? Any other chart codes you know? Yes. Any other chart codes? Yes, chart code joint. Good. So he is Jean Mary Charcot, and Charcot triad 1 it comes in MS, then Charcot triad 2 your cholangitis and Charcot's joint. And jaundice with pain. In what condition you get pain? Whenever there is a all obstruction will not cause pain. Jaundice with pain, when do you get? If it is due to a stone disease, it will be painful. Okay. If it is due to malignancy, will you get pain? In a later stage, when there is infiltration, you might get pain. Otherwise, you will not get pain. So typical pain with obstructive jaundice more in favor of stone disease. What is this Pentrad? Raynaud's Pentrad. When do you get this? Ascending cholangitis. When you get cholangitis, you have this Raynaud's Pentrad. Then you have this painless progressive jaundice. What is that? It's due to, I told you, it's due to painless progressive jaundice due to malignancy. And you have two common malignancies. As for undergraduates, we'll have two things. One is CA head of pancreas, and the other one is periampullary carcinoma. So typical of carcinoma head of pancreas is painless progressive jaundice. On later stage, when the posterior wall is infiltrated, you get pain. Whereas in periampullary carcinoma, the typical description of jaundice is waxing and waning. What is that waxing and waning? So in contrast, you have one more jaundice. What is that? Intermittent jaundice. What is the difference between intermittent jaundice and waxing and waning jaundice? In intermittent jaundice, the baseline will come to 0. Okay. Whereas in waxing and waning, it will not touch the normal level. Okay. Why? Because in periampullary carcinoma, there is rapid proliferation, the tip necrosis, and a part of the obstructed bile, it gets flown into the duodenum. Whereas the obstruction is not fully relieved. In due course, again the malignant cells proliferate and obstruction occurs. So this is waxing and waning. Whereas in case of stone, when the stone passes, the whole obstruction is relieved till the next stone comes and obstructs. Okay, so it touches the baseline. So this is about your intermittent and waxing and waning type of jaundice. So this is an endoscopic picture of an periampullary carcinoma. When it comes to carcinoma gallbladder, you have a right hypochondriac pain, obstructive jaundice. There will be hard mass in the right hypochondrium. Early cases will present with acute cholecystitis. We have one thing called the cholangiocarcinoma, which is again a painless obstructive jaundice of shorter duration. The liver will be hard, palpable, and the gallbladder will be palpable if the obstruction is distal. If the obstruction is proximal, the gallbladder will not be palpable. Cachexia and anorexia will be a feature. So for undergraduates, we will stick on to 3 causes of obstructive jaundice. One is obstructive jaundice due to stone disease, obstructive jaundice due to malignancy, 2 malignancies, periampullary carcinoma and carcinoma head of pancreas. So what next? What will you do? Go in for investigations. First and foremost, what is that? Liver function test. In that what you have? ALT, AST, alkaline phosphatase, prothrombin time, albumin, gamma glutamyl transferase, and bile acids. That SGOT and PT, what does they signify? They signify hepatocellular damage. Whereas in obstructive jaundice, which will be elevated, alkaline phosphatase, that signifies there is cholestasis, right? And prothrombin time will be elevated, albumin will be low. Okay, they signify the synthetic function of the liver is jeopardized. And about this alkaline phosphatase, in obstructive jaundice, how many times it will be elevated? It will be elevated more than 3 times the normal range. Okay, so it might be elevated in elderly patients, pregnant women, and in adolescents with rapid bone turnover also. Okay, so if it is elevated more than 3 times, that is significant. So urobilinogen and bile salts, as I already told you, this is metabolized in the large intestine, but a fraction is excreted in urine, less than 4 mg per day. And normally bile salts, will it be present in urine? No. Obstruction in the biliary passage causes leakage of bile salts into the circulation, which leads to excretion in the urine. So bile salts and bile pigments urine கண்டுபிடிக்கிற டெஸ்ட் பேர் என்ன? Good. Faucher's, Hayes, and you have one more test called the G-Melin test. Nowadays, any other tests we are doing for finding the bilirubin? Previously, it was Vandenberg's test. Nowadays, we have the semi-auto analyzer. We use that. So, the next modality of investigation is ultrasound. It is a screening modality. It is operator dependent, and distal CBD cannot be visualized in an ultrasound. Okay, and IHBR dilatation, hyper echogenic lesions can also be made out. Ascites can be made out, and portohepatitis nodes can be made out in ultrasound. If GB is distended, I already told you what is it due to. Of the three diagnoses, GB is distended, so it is periampullary or C-head of pancreas. We go in for what CT? Pancreatic protocol CT. Can anybody tell me what is that? Yes, good. Good. Okay, so arterial phase, we can pick up the hypervascular tumors, late arterial or the parenchymal phase, and then you have the portal venous phase. That is taken in the 70 seconds. You use it for venous encasement. And you have to look for complications of obstructive jaundice like cholangitis, gastric outlet obstruction, secondary biliary cirrhosis, and portal hypertension. This can be looked up for CT. If GB is not distended, what investigation you have to go in for? You have to go in for MRI or MRCP and look for the T2 weighted sequences. Ducts above and below the obstruction can be visualized, and it is preferred in choledocholitis, strictures, cholangiocarcinoma. Biliary anatomy will be better visualized with MRI or MRCP. These are all the certain diagnoses. And indications for ERCP in obstructive jaundice. It is both therapeutic and diagnostic. Just for diagnostic purpose, we don't usually use ERCP in a obstructive jaundice patient. So when there is a therapeutic indication, you can go in for ERCP. So in ERCP, you can do a sphincterotomy, and then sphincterotomy we do for what? When there is a stone obstructed in the ampulla of Vater, you do a sphincterotomy and remove the stone. You have a if the stones are higher up in the CBD, what you use? What is the name of the catheter you use to remove it? One basket. Damio basket. Okay, you can remove the stones in the CBD. Okay, it's an invasive imaging. Biopsy can be taken from the periampullary region, or brush cytology can be done. It is it's invasive, and it has some complications also. So role of tissue diagnosis, when you suspect CA head of pancreas, do you need a tissue diagnosis? No. For CA head of pancreas, you don't need a tissue diagnosis. Okay, you can, if you suspect with all these imaging modalities, you can go in, proceed with your treatment option, right? If it is a periampullary, you visualize, you take up the tissue for test, either with the side viewing endoscopy or your ERCP. And coming to staging laparoscopy, what is that? Yes, peritoneal mets cannot be visualized in any other modalities, and moreover, whether it is operable or not, that can be well visualized with the staging laparoscopy. Okay, and if it is operable, you can proceed with surgery. If not, you can stop with this, take a biopsy, and come out. So how do you prepare the patient for surgery? If the patient is fit, you optimize the patient. If it is an operable tumor, you optimize the patient. Okay, how do you optimize? You correct the hydration, you give enteral or parenteral feeding, give proper diuresis, coagulation profile should be corrected with the vitamin K for 5 to 7 days, or FFP can be given, control sepsis with proper antibiotics. And then what is the procedure we commonly do for CA head of pancreas or periampullary carcinoma? It is called Whipple's pancreaticoduodenectomy. If it is going to be CA head of pancreas, why do you want to remove the duodenum? Okay, you can remove the nodes. If it is going to be periampullary carcinoma, it is in the second part of duodenum. Why do you want to remove the head of the pancreas? Anybody? So whenever you're going to remove an organ, first and foremost, what will you ligate? Before doing appendicectomy, what is the first clamp you apply? To the appendicular artery, right? When you're doing hysterectomy, where do you put the clamps? You ligate the uterine arteries, okay, right? So likewise, when you are going to take up the head or the duodenum, C-loop of duodenum, it shares a common blood supply. What is that? Duodenal artery. So that should be ligated. So you remove the whole thing. That blue shaded things are removed. What are they? The distal stomach, okay, right? And then pancreas la iduvaraikkum you remove the head and neck of the pancreas, C-loop of the duodenum, and proximal 10 centimeters of the jejunum is removed, okay, and the gallbladder is also removed. So what are the remaining things which are opened up? The pancreas is there, the stomach is there, and the common hepatic duct is there, okay. The blue things you are removed, okay. What are the remaining things? Pancreas, stomach, and the common hepatic duct. So you have to join all these three. How you are going to join it? With the help of a loop of a jejunum. So what are the three anastomosis? Hepatico-jejunostomy, gastro-jejunostomy, and pancreatico-jejunostomy, right? Okay. And if you go in and find it, it's going to be inoperable, you can do a palliative procedure. What is that procedure? It's called triple bypass. What are the things you are going to bypass? You are going to bypass the food. So what is it you are going? What anastomosis? Gastro-jejunostomy. You are going to bypass the bile. So what are you going to do? Cholecysto. Okay, here it is cholecysto-jejunostomy. And what is the third anastomosis? Do we drain the pancreatic secretion? We don't do, okay. So the third anastomosis is jejunostomy. It is not pancreatico-jejunostomy. So you have to note it here. And if the patient is very sick, you cannot proceed with these surgeries. Endoscopic stenting can be done. So the third diagnosis, benign obstructive jaundice due to CBD stone. What are the treatment options available? I told you one thing, ERCP stenting, you remove the stones, right? Otherwise, you can do laparoscopic or open CBD exploration, remove the stones, and either you could primarily close the CBD or drain with the T-tube, or you can do a choledochoduodenostomy. Okay, drainage procedures can be done. And I think with this, it's over. So, from the Department of General Surgery, Government Thoothukudi Medical College, we wish you all the best for your exams. Thank you.
Thank you, sir, for an insightful presentation. Now, nextly, case presentation on obstructive jaundice by Tony Ashwant.
People answering pancreatic protocols and ERCP uses and all. It's really good, and I think I hope you have got good set of teachers here, from Jalal sir to Professor Nixon. Great teachers, it seems. And I thank Professor NIRMAL sir for having covered extensively the entire obstructive jaundice. And I think the previous presenter was very good. She was quite calm and composed, and she was answering the questions. And having NIRMAL sir cover the entire topic, I think this presenter should be able to answer all the questions, right? Straightforward. Good. Okay, we'll go ahead.
Very good afternoon to one and all present here, respected faculties. So I'm here to present a case of obstructive jaundice. So introduction, my patient is a 73-year-old gentleman, a resident of Nagarkoil, who is a coolie by occupation. He had presented to the general surgery OPD 10 days back with chief complaints of exacerbation of abdominal pain for 2 days. So moving on to the history of presenting illness, my patient had been suffering from bouts of vague upper abdominal pain for the last 3 months. The pain was not radiated elsewhere and was continuous in nature. The pain was aggravated after meals and relieved by bending forward. 12 days ago, he had an exacerbation of the pain, which is associated with 2 episodes of vomiting, which was non-foul smelling, non-bilious, non-blood stain, and the vomitus contained digested food. Subsequently, he visited a clinic in his locality, and there he was found to be icteric and was referred to our hospital for further management. Again, there was history of jaundice for the last 12 days. It was initially noticed only when the patient visited his local clinic, and initially there was only scleral icterus present. Now, over the last 12 days, it has progressed to involve the palms. There was no waxing and weaning character, and it was not associated with fever. There was history of passage of high colored urine for the last 15 days. So before this episode of exacerbation of pain, my patient noticed high colored urine, but he didn't bother about it, and later he developed this. And there was history of loss of appetite and loss of weight for the last 6 months. And there is no history of passage of clay-colored stools, abdominal distension, pruritus, melena, and any symptoms corresponding to metastasis such as cough, hemoptysis, altered sensorium, or bony pain. And past history, my patient has no history of any chronic drug intake, no history of similar complaints in the past, and no history of any blood transfusion. Personal history, the only significant history is he's a chronic consumption of alcohol history for the last 40 years. He consumes around 375 ml of alcohol per day. And his last he consumed alcohol was around 15 days ago, and he consumes a non-vegetarian diet, and his bowel and bladder habits are normal. So family history, there is no history of breast cancer, pancreatic cancer, colonic cancer, or gynecological tumors in his family, and both his parents died of natural causes. So summary, so positive findings of history, he has vague abdominal pain that is localized to the right quadrant and epigastrium for the last 3 months. And he had an acute exacerbation with 2 episodes of vomiting 12 days ago. There is jaundice for 12 days, which is progressive. There is passage of high colored urine for 15 days, and loss of weight and loss of appetite. And personal history wise, he has a history of chronic consumption of alcohol, 375 ml for the last 40 years. So provisional diagnosis, so with history, it is probably a case of obstructive jaundice, probably due to malignant etiology.
So why do you say the patient is jaundiced?
Sir, because I'm suspecting that it could be a obstructive malignant etiology, sir. So what comes to my mind is...
No, let it be. It could be obstructive jaundice, or it can be anything else. My first question is, why you say that the patient is jaundiced? Why do you say the patient has got jaundice?
Sir, there was scleral, initially when he was admitted to his local clinic, they found there was scleral icterus, sir, and also the icterus was progressive in nature to involve the palms later, so palms. Yeah.
That's right. The answer should be like the patient had a yellowish discoloration of his eyes. That's the reason, right? That's how we make out a jaundice. Right. So initially it was a yellowish discoloration of the eyes.
Yes, sir.
And now it has become yellowish discoloration of the palms. So what does that mean?
So it means it's a progressive jaundice, sir.
Why do you say so?
So because based on the bilirubin level, sir, usually if the bilirubin level is around 2.5 to 3, initially there will be only yellowish discoloration of the sclera, sir. So when it has progressed beyond that, when the bilirubin is around 10 milligrams per deciliter, that's when we'll be getting yellowish discoloration of the palms and soles, sir.
Good. So that's good. So it's the dermal discoloration starts around 5 milligrams. It's not 10. 5, and palms it takes a little more, right? Around 7, 8 it becomes yellowish discoloration of the palms. So you mean to say that's progressive?
Progressive,
right? Fine. Then why do you say it's obstructive?
So because
what are the different types of jaundice?
So
anyone who's coming to your clinic, he may have a yellow discoloration of his eyes.
Yes, sir.
So what are the different types of jaundice?
Sir, basically there are 2 types we can categorize. So one is a surgical jaundice and one is a medical jaundice, sir. So with the medical jaundice, the patient will have constitutional symptoms, sir. Maybe a fever or a malaise. And also, again, if it is due to a chronic liver disease, he might be presenting with symptoms of chronic liver disease, maybe an altered sleep pattern, etc. While for a surgical jaundice, these symptoms won't be present. So maybe the patient might be having an abdominal pain and he might have developed jaundice. So only this will be the commonest presenting symptom in a surgical jaundice.
What is an achaluric jaundice?
Sir, achaluric jaundice is when there won't be any, there will be absence of urobilinogen in the urine, sir. This is also another name for obstructive jaundice, sir.
Is it?
Sir, so when there will be...
What is hemolytic jaundice?
Sir, hemolytic jaundice is prehepatic jaundice, sir, where there will be elevation of unconjugated bilirubin, sir, due to the hemolytic process.
So achaluric jaundice is a jaundice where the urine is not yellowish in color. That is known as achaluric jaundice. That happens in hemolytic anemia where you don't get bilirubin in the urine, right? Only conjugate bilirubin can get excreted in the urine. So that you get in obstructive jaundice. So obstructive jaundice is yellowish discoloration of the urine. You have that.
Yes, sir.
Right. So you have three types of jaundice primarily. You have a parenchymal jaundice, right, due to parenchymal liver diseases. You have a pre-hepatic jaundice, which is hemolytic jaundice, and you also have a post-hepatic jaundice, which is an obstructive jaundice. So when the patient is coming to you, you need to find out to what category this patient belongs to. Now you say this patient has got obstructive jaundice. Why do you say this patient has got an obstructive? What are the features to say that this patient has got obstructive jaundice?
Sir, first, there is no constitutional symptoms in the patient, sir.
Good.
Of any fever or malaise.
Okay,
Then his
fine.
only symptom is he's having a vague upper abdominal pain, sir, for the last 3 months. And he has developed developed jaundice. And plus, there is he didn't give any history of any altered sleep pattern or any history pertaining to the parenchymal liver disease, sir.
So you don't get upper abdominal pain in parenchymal jaundice.
Sir, we can get an upper abdominal pain in
What's the reason?
Sir, either if the patient has gone for cirrhosis, sir, and secondary if there's a development of a carcinoma, that may present with an upper right upper quadrant pain, sir.
A simple viral hepatitis, the patient can have an upper abdominal pain, right? Enlargement of the liver due to stretching of the Glissen's capsule can produce an upper abdominal pain. So these could be the simple reasons for a upper abdominal pain. So this patient has got a vague upper abdominal pain for the last 3 months.
3 months, sir.
Apart from that, what else do you have to say that it's a case of obstructive jaundice?
Sir,
So
plus
okay, we'll come to that.
Yes,
What are the features to say that the patient has got an obstructive jaundice?
sir, they
Then
should,
leave this patient.
sir, there should be history of passage of high colored urine, sir.
Good.
Associate. There can be associated melena.
Melena?
Melena. Sir, clay colored stools or melena, sir, in certain cases.
Clay-colored stools can be a feature of will be a feature of obstructive jaundice, but not melena as such in all cases. All cases may not have melena, right? That is not a feature of obstructive jaundice. That is a feature of upper GI bleed. So that can happen in cases of certain cases of obstructive jaundice can happen. For example, in a periampullary carcinoma, you can have a melena also. But clay-colored stools is one thing. Then,
Sir, clay colored stools.
so why does the patient have a clay-colored stool?
Sir, because there won't be formation of stercobilin, sir, because the bile is not being able to pass into the intestine.
Okay, good,
Yes,
good.
sir.
Right. Then, what else? What are the other symptoms a patient can have?
Sir, patient can have itching or
Right,
pruritus.
pruritus,
Yes,
right?
Yes, sir.
Why does the patient have pruritus?
Sir, there can be two reasons to this, sir. First thing, the bile salts, they can be irritant to the peripheral nerves, sir. And second, the bile pigment, when they deposit in the dermis, it can cause mast cell degranulation and release of histamines.
Good. Right. Does your patient have both of these?
No, sir, he doesn't have, he didn't give any history of pruritus to me, sir.
Right, which means that stercobilinogen is reaching the intestine and the patient is passing yellow-colored stools. Am I right?
Yes.
But then still you want to say that's an obstructive jaundice.
Sir, he's having history of high-colored passage of high-colored urine, sir. He's saying.
That you get in jaundice.
Jaundice.
Any jaundice, there will be high-colored passage of high-colored urine. Am I right?
Yes.
Jaundice we diagnose with the yellowish discoloration of the sclera and passing high-colored urine. Right?
Yes, sir, then his age and his loss of weight and loss of appetite is also present over the 6 months.
That will come to the pathology of the condition. Now I want to know whether it's obstructive jaundice or not.
Sir, since history-wise, he didn't give me any history with any constitutional symptoms or due to any parenchymal liver disease, sir. So I'm suspecting this could be a case of surgical jaundice or obstructive jaundice, sir.
Sometimes the patient can have alternating yellow stools with clay-colored stools, right? That may be because of waxing and waning of the jaundice. There may be sloughing of the periampullary lesions, and the patient can have little amount of bile entering into the duodenum, and then can have a normal stool, and again he can have a clay-colored stool, something like that. Yes. But without a passage of clay-colored stools, I don't think you can make a diagnosis of an obstructive jaundice at undergraduate level.
So what is this relieved by bending forward? What does it signify?
Sir, it signifies maybe the disease process could involve the pancreas, sir. That could signifies that because when the patient leans forward, there will be a separation of the parietal peritoneum. So hence, the sensation won't be traveling to the central nervous system, sir. So the patient will have a relief of pain.
Okay, and the patient has got 2 episodes of vomiting.
Yes, sir.
What does that mean? What does it signify?
Sir, it could be a reason, it could be a gastric outlet obstruction, sir, because he has 2 episodes of vomiting which contained partially digested food, which was non-small swelling and non-bilious. So what I'm suspecting is that probably could be a malignant etiology which has begun in the pancreas or in the periampular region that has gone to go for a gastric outlet obstruction. Sir.
Okay, and he gives history of loss of weight and appetite for 6 months.
6 months.
What do you mean by significant weight loss?
Sir, significant weight loss is unintended loss of 5% of body weight over 3 months or 10% in 6 months. Sir.
Okay, why history of altered sensorium, seizures?
So that is pertaining to metastasis, sir. Pertaining to metastasis, hepatobiliary tumors, sir. They can, in very rare cases, they can metastasize to the CNS. That is one. And also, if the patient, if he had any episode of acute cholangitis, so that time he might present with the features of Raynaud's pentad. So whether he's had any recurrent episodes of acute cholangitis for that.
Which is more common?
So recurrent episodes of acute cholangitis will be more common, sir.
And that bony pain?
Sir, bony pain again for metastasis for hepatobiliary tumors, sir.
Why that abdominal distension?
Sir, abdominal distension, sir, first to ascertain if there was any hepatomegaly, just in retrospective, if there was any hepatomegaly or any ascites, because he gives a history of consumption of 40 years of consumption of alcohol, sir. So if this could be any ascites or hepatomegaly, I wanted to inquire that.
Okay, pertaining to alcohol consumption, can you correlate anything with the jaundice?
Sir, so first of all, alcohol consumption, sir, per se, it can lead to cirrhosis, sir. And cirrhosis is a risk factor for the development of hepatocellular carcinoma, sir, rather than carcinomas of the extrahepatic biliary apparatus. So it's a rare possibility. My patient, he doesn't give any history of abdominal distension, but it could be a possibility that he's having hepatocellular carcinoma, and that could have presented as a jaundice.
Okay, can it be he's going in for liver cell failure?
Sir, no, sir, because clinically, when history-wise, he doesn't give any history, sir, like history of any altered sleep pattern or anything. And also examination-wise, there was no signs of liver cell failure, sir, when I examined the patient.
Okay, proceed with the general examination.
So general examination, my patient was conscious and oriented with time, place and person. My patient appeared to be dehydrated and he was afebrile. Patient is cachectic. Icterus is present. There is yellowish discoloration of the sclera as well as the palms. Pallor couldn't be assessed. Clubbing was present, grade 2. There was no cyanosis, pedal edema or generalized lymphadenopathy. Vitals, pulse was 67 beats per minute and his blood pressure was 120 by 90 millimeters of mercury. Sir.
He is dehydrated, right?
Yes. When I examined him, he was dehydrated.
He was dehydrated. He is hospitalized for how many days?
Sir, currently he is hospitalized for 12 days, sir.
12 days.
12 days, yes.
And in dehydration, what will happen to the pulse?
Sir, dehydration, there could be a tachycardia will be present, sir.
Okay.
Sir, but sir, since in this case he is jaundice, sir, he can have a bradycardia. He can be bradycardia.
Why?
Sir. So because the bile salts, they can go to the sinus node and they can cause a sinus node depression, sir. So that will present as a relative bradycardia.
Okay.
Sir, examination of the abdomen. On inspection, the abdomen is scaphoid in shape. All quadrants move equally with respiration. The umbilicus is in the midline and inverted. No scars or dilated veins present. All the hernial orifices are free. No visible gastric peristalsis or intestinal peristalsis, and no visible swelling in the supraclavicular fossa. On palpation, there was no warmth or tenderness, no organomegaly, and the left suprapalpebral node is not palpable. On percussion, the liver span was 10 centimeter, and there was no evidence of free fluids. On auscultation, the normal bowel sounds were heard. An examination of the other systems, CVS, S1 and S2 heard. No added sounds or murmur. RS, normal vesicular breath sounds were heard, and CNS, there was no focal neurological deficit. Sir, diagnosis, it is a case of obstructive jaundice, probably of malignant etiology, and with the patient's symptoms and history, most probably it could be carcinoma of head of pancreas. Sir.
So inspection and palpation, no finding.
No findings. I have no findings.
Why did you look for the supraclavicular node?
So because that is a common site or sign of advanced disease in GI tumors, sir. Via the thoracic duct, these tumors, they can, in advanced cases, these tumor, they will directly drain to the left supraclavicular node, sir. Yes, sir.
Okay, what is the sign called?
So it is called atrocious sign, sir.
Right. And how do you look for free fluid in the abdomen?
So there are 3 methods, sir, depending on the amount of free fluid that is present. For minimal amount of free fluid, we can do a puddle sign, sir. We have to put the patient in knee elbow position and you have to percuss over the umbilicus. If there is a dull note, then it is there is mild amount of ascites. For moderate ascites, we can do a shifting dullness, sir. For tense ascites or massive ascites, fluid thrill we can do.
Okay, nowadays you are not supposed to do that.
Puddle sign.
Puddles. Okay, right. So why do you say it is? It could be a case of carcinoma of pancreas.
Sir, because sir, my first doubt was because the patient he had symptom of vague upper abdominal pain, sir, and the pain was especially relieved by bending forward. So again, this is common in advanced cases of pancreatic cancer. The patient might have this pain, and also the way it was being relieved, it brought me that suspicion. Other than that, he's having obstructive jaundice, sir, and there is history-wise there is a loss of appetite and loss of weight for the last 6 months.
Okay. If it is a mass arising from the pancreatic head, what will be the findings you will get? Here there is no mass. You didn't palpate. Okay, you couldn't find a mass. If it is a mass arising from the pancreas, what will be the finding you will get? To say it is a pancreatic mass.
Sir, first of all, the mass will not move with, it won't move with respiration, sir, on
Yes.
examination. And then so the lower border won't be palpable. So lower border won't be palpable.
Lower part, why? Okay, it will not be move with respiration. And consistency,
So consistency, sir, it will be hard in consistency, sir.
because it's a malignancy.
Malignant
Okay,
mass.
hard in consistency. Then
Sir, borders will be ill-defined borders, sir. And surface, it could be nodularity may be present, sir, on the surface.
okay, where it will be present that mass?
Sir, right iliac fossa. Yeah. Sir, I'm.
What are the regions of the stomach? Regions of the abdomen?
Sir, right hypochondrium, epigastrium, left hypochondrium, right lumbar region, hypogastrium, left lumbar region, right iliac fossa, pubic region, left iliac fossa, and then the 10th quadrant is the external genitalia. Sir.
Okay, so this mass, pancreatic head mass, can occur in which?
So it could be in the epigastric, region.
Could be in the epigastric. Where else it can come?
It's in the epigastric region. It forms the stomach bed, no? Pancreas forms the stomach bed.
Stomach bed, yes, sir.
Stomach is in the epigastrium.
Yes, sir.
So you will get a mass in the epigastric
Epigastrium.
area, right?
Yes, sir.
So what are the differential diagnosis for a mass in the epigastric region?
Sir, it can be sir, carcinoma of stomach, sir, distal carcinoma of stomach. It can be carcinoma of head of pancreas, sir, and also in the it can be also an enlarged para-aortic node, sir.
Okay, and liver can come there.
So liver, maybe we can also get a liver enlargement.
How will you differentiate all these 4 things?
Sir, first of all, for a liver mass, if it is a liver mass, sir, the liver mass will actually move with respiration, sir, and the finger insinuation will not be there, sir.
Yes, good.
And also again, if for a pancreatic mass, again the mass won't move with respiration. And for a para-aortic node, the mass will be fixed to the abdominal node. It will be fixed, sir. Again, the respiration won't be there. It won't move with respiration if it is a malignant node. And so if it is a stomach mass, the other clinical signs will be positive. So if they can be visible gastric peristalsis on examination,
Okay.
or a succussion splash will be positive, sir.
Okay, what will be the feel when you palpate? How it will be? Stomach mass and a pancreatic mass.
Sir, a pancreatic mass will be hard in consistency, sir.
Yes.
While a stomach mass, it will be usually firm to so.
Malignancy? If this
Hard-
is a
hard-
malignancy.
a malignancy is
in
hard consistency.
Okay, right. Okay. And with this diagnosis, your first and foremost is carcinoma head of pancreas.
Pancreas, yes.
Okay. Right. How will you proceed with your patient?
So I'll proceed with investigation to confirm my diagnosis, sir. The confirmatory investigation for my diagnosis is CECT pancreatic protocol, sir.
Your first investigation will be CECT.
No, sir. First, I'll proceed with the ultrasonogram of the abdomen, sir.
Okay.
So in the ultrasonogram, I'll look for if there's any free fluid present, sir. I look for the liver, if there is any nodularity or if there are any secondary metastatic deposits present, sir. I look for the portal vein, if there's any dilatation of the portal vein. And then I look for the extrahepatic biliary apparatus, if there is any dilatation proximally, and also the gallbladder, if the gallbladder is dilated, or any stone is present in the extrahepatic biliary apparatus, sir.
Okay. Can your ultrasound pick up carcinoma head of pancreas?
Sir, if the disease process, if it causes a compression on the distal bile ducts and there is a proximal dilatation of the biliary hepatic ductules, we can make out there could be a distal obstruction, sir, but otherwise it can't pick up the carcinoma of head of pancreas.
Can it pick up periampullary carcinoma, ultrasound?
So periampullary carcinoma, it can pick up periampullary carcinoma, sir, but again the more significant finding will be the dilatation of the proximal biliary ductules.
Okay. And then you proceed with?
So I'll proceed with the next imaging modality, sir, that is CECT pancreatic protocol, sir. There again I'll look for if there is any, I'll stage, that is for done for staging the disease, sir. Whether the disease is limited to the pancreas, where it has extended beyond, is there any local involvement, or if there is any nodal involvement, sir. And we can also assess the resectability of the tumor based on the CECT pancreatic protocol, sir.
Okay, before going to the resective, what will be the liver function test like?
So liver function, there will be an elevation in, since it's an obstructive etiology, there can be elevation in alkaline phosphatase, sir, 5 nucleotidase or gamma glutamyl transferase, and the prothrombin time will be elevated, sir.
Bilirubin?
So bilirubin, there will be more of conjugated bilirubinemia, sir, and bilirubin, total bilirubin will be elevated with more elevation in conjugated bilirubinemia.
Okay.
Any other blood tests you want to do?
So the tumor markers can be done, sir, for this patient.
Yes.
CA 19-9 and CEA, sir. Two tumor markers can be done.
Right. Any other profile you want to do? Liver function test, tumor markers, anything else?
So we can
Associated with the prothrombin time?
sir, and coagulation profile can be
Profile.
also
Okay. Right. And why this ECG, echo, pulmonary function test?
So that is to assess the anesthetic fitness of the patient, sir, for surgery.
Okay, whether he is fit for surgery or not.
Surgery,
Okay, right. So with this, any other advanced modality, investigative
So
modality?
there can be endoscopic ultrasound can be done, sir.
Yes.
That is done for periampullary carcinoma using a 7.5 to 12 megahertz transducer. We can delineate the walls of the periampullary region, sir, and again it can be used for staging also, depending on the wall involvement.
It can be used only for periampullary.
So also for duodenal adenocarcinoma, sir.
Can be used for C-head of pancreas.
Pancreas also.
Pancreas also. Okay. When you say periampullary carcinoma, within how much diameter the
Sir,
lesion should be?
2 centimeters.
Within
2 centimeters.
2 centimeters. Okay. Right.
So that was a great presentation, man.
Thank you, sir.
That's good. But this knowledge is extensive, and one thing you should remember is that this hepatobiliary system is a no man's land. It can be either a medical, even it goes to medical causes, we have surgical causes also, right? So whenever you get a jaundice, since you are in the department of surgery, I think you are presenting as an obstructive jaundice. But if the same case go to the medical department, you are going to present this case in the medicine department. I think he is going to present this case as a case of an alcoholic liver disease because he is an alcoholic for 40 years and he doesn't have clinical issues like that, right? So it's like that. So you can present it this side or that side, anything. But as far as your undergraduate level is concerned, not only for undergraduate, for anyone, if the patient, at least for me, at least I will not diagnose a case of an obstructive jaundice without a clay-colored stools and a pruritus. So there are certain classical features you need to have to diagnose a case. So you need to have jaundice, and if the patient is jaundiced, you need to know whether this patient is, that was the initial question I asked you. You need to know, confirm whether this patient is jaundiced at all. How do you confirm the patient is jaundiced? Because you have got yellow discoloration of sclera, yellow discoloration of palm, skin, everything, undersurface of the tongue, all that it has, then you say the patient is jaundiced. If the patient is jaundiced, then you need to find out whether it's a medical jaundice or a surgical jaundice. If it's going to be a surgical jaundice, the classical features will be the patient will have an clay colored stools, a pruritus, and of course you can have certain other features also, like in obstructive jaundice. So you need to have these to diagnose a case of obstructive jaundice. And then if the patient has got this jaundice, which is progressive and which is painless, then you can think of a malignant etiology. If the patient has got a painful progressive jaundice, intermittent jaundice, you need to think in terms of a cholelithiasis. You have to think in terms of a stone disease or something else like a clonacis or ascariasis or something like that. Right. So it is this step you need to go. So still I am not convinced that this is a case of an obstructive jaundice. We need to have to, since a virtual case, you are not able to pick up things. Maybe we have to examine the case more, talk to him in more detail to find out this case. Anyway, whether it's obstructive jaundice or medical jaundice, we are not sure, but his knowledge about jaundice and this are talking about endoscopic ultrasound, its frequency, everything is great. So that was very good.
Thank you.
Can you go to the first slide? First slide. So his presentation was great, except that I'll finish with one remark. Nagarcoil is a great place. I love Nagarcoil and I am a product of Carmel School, right? And putting small n for Nagarcoil is not acceptable, right? Thank you so much for the opportunity. I thank Selvin sir and Nixon for having given us this opportunity. Thank you so much.
Thank you, sir.
Thank you. All the best.
Thank you.